In this lecture we will study about the radicular cyst, which is also called as a periapical cyst, apical periodontal cyst or dental cyst. How to define the radicular cyst? It is one which arises from the epithelial residues in the periodontal ligament as a result of inflammation. So, radicular cyst is the most common type of the odontogenic cyst. Overall, it is the most common type of the odontogenic cyst and most common type of the inflammatory cyst. It is inflammatory in origin. What is radicular? Something related to the roots. In the, when we know that Hertwig epithelial root sheet, its residues which are called as the cell rest of Malaise. So these are the tissue of origin for the radicular cyst, cell rest of Malaise. So we have two types of radicular cyst. First is a true cyst. Two type of the radicular cyst or the periapical cyst, which are lined by the epithelium. Epithelium is formed by the Hirsch remnants or the cell rest of Malaise. And second type is, we called it as a base cyst or the pocket periapical cyst. So they are lined by the epithelium, partially lined by the epithelium, which is derived from the partially lined by epithelium, and this is derived from the respiratory epithelium of maxillary sinus and from the oral epithelium from fistulous tract. So very important, etiopathogenesis of the radicular cyst. So in this we have the four phases. First is a phase of initiation. Second is a phase of proliferation. Third is a phase of cystification, and last one, phase of cyst enlargement. So before coming to the pathogenesis, we have to know that etiology. So we know that it is inflammatory in origin. Radicular cyst is inflammatory in origin. So trauma, inflammation to the pulp, necrosis, pulp death, or the epithelialization of the periapical granuloma all lead to the formation of the radicular cyst. So any inflammatory stimulus or any inflammatory causes or stimulates the Hirsch remnants. Hirsch is Hertwig epithelial root sheet, which is responsible for the formation of the tooth root. So its residues are called as a cell rest of Malaise. So they start proliferating in response to the inflammation to pulp. So this was all about the phase of initiation. Now coming to the next phase, but before that the question arises how the cells actually proliferate. So how the cells actually proliferate? Now we see that the proliferating cells shows that they proliferate via the HMP shunt or the HMP pathway. How? Because proliferating cells shows change in the nucleocytoplasmic ratio, and they utilize the glycogen, change in nucleocytoplasmic ratio, and there is increase in the G6PD activity, that is glucose 6-phosphorodehydrogenase enzyme activity, and decrease in the succinate dehydrogenase enzyme activity. So now we know that they proliferate via HMP shunt. Now there are other theories by the group and Tenkate that how the cells actually proliferate. So they said that inflammation causes the local changes in pH, there is increase in the carbon dioxide and the decrease in the oxygen tension. So they all lead to the stimulation of the Hirsch remnants or the Hirsch residues. So that leads to the formation of radicular cyst. So this we called it as a phase of proliferation. Now the question arises that how there is a formation of the cyst. We called it as a phase of cystification. Now we know that there are the cells proliferation, and proliferating cells, obviously we know that they need the blood supply or they need the nutrition when the cells are proliferating. But now the central cells become devoid of the blood supply or the nutrition, so they starts to die. There occurs a liquefactive necrosis of the central cells. So now you got that how the cyst actually forms. So this was the phase of cystification. Third phase of cystification. Now we know that in center we have cyst, and cyst is lined by the cells, epithelial cells, and now there occurs the desquamation of these epithelial cells. How the cyst actually enlarges? By desquamation of the epithelial cells or the inflammatory cells into the cystic lumen. So they lead to the change in the osmolality. They create a difference in the osmolality. For maintaining this balance, there comes the water or the transudation of fluid. There occurs the expansion of the cyst. Now you got that how the cyst actually enlarges, and this phase is called as a phase of enlargement. So clinical features: males are more commonly affected, so it is more common in the 2nd to 6th decade of the life, and whites have more prevalence than blacks, as same as that of the dentigerous, and it is most commonly occur in the maxillary anteriors. Why maxillary anteriors are most commonly affected? We have several reasons. The first reason is that there is increase in number of silicate restorations due to the aesthetic region that have the increased risk or the increased chance of trauma to the pulp. So second reason we have, like maxillary anterior or the maxillary incisors have an increased risk of trauma or the injury, and we know that there is a trauma or the inflammation in the etiology. So clinical presentation of radicular cyst. Sine qua non, original called as a sine qua non, that is the essential condition for the radicular cyst is tooth present with that of non-vital pulp. Tooth will be in the oral cavity, but then it will be non-vital. So there may be the presence of pain and radiographic features. So as we know that it is present periapically or at the site of the apical foramen of root. You can appreciate the periapical radiolucency in the X-ray. So it have a well-defined border. So maxillary incisors, there is a root resorption. So it causes a root resorption sometimes. So other reasons which shows a periapical radiolucency, first is a periapical granuloma, periapical abscess. So these all are included in the differential diagnosis for the radicular cyst. So how to differentiate? Periapical granuloma is of small size and periapical abscess have a ill-defined border. So one other lesion which shows the periapical radiolucency in the initial stages is that the periapical segmental dysplasia, but it will be associated with the vital tooth. So we have another variety of the radicular cyst. We called it as a lateral radicular cyst. Another was the periapical cyst, periapical or the radicular cyst, which is present periapically. So it is present laterally to the tooth. So differential diagnosis is a lateral periodontal cyst. So now we know that radicular cyst will be always associated with a non-vital pulp and LPC is associated with the vital pulp. So coming to the histopathological features, firstly we have to mention that what is the lining epithelium. So we know that it is stratified squamous epithelium. Now secondly, what is the thickness of the lining epithelium? So it is highly variable in the radicular cyst because it is inflammatory cyst. It is 6 to 50 cellular thick. it is highly variable. Now, most important point, there is a arcading pattern of the retiridges or the epithelium. So, arcading derived from the word arcades, that means the network. So, there is a network of the epithelium in the connective tissue. So, why there occurs the epithelium proliferation in the connective tissue? So, now we know that normal pattern of the retiridges normally, and now there occurs an inflammation in the radicular cyst. So blood vessels start to secrete the inflammatory mediators. So in response to these inflammatory mediators, the epithelium starts to proliferate in the connective tissue. So we call it as a arcading pattern. So now you can see in the histopathological picture there are clear spaces which are called as the cholesterol clefts. Now you can see in the picture they are seen in the connective tissue. So what are the cholesterol clefts? These are the clear spaces seen after the removal of the cholesterol crystals or in the place of the cholesterol crystals in the connective tissue. So in the another one you can see like there are the Russian bodies, we called it as the Russian bodies or the hyaline bodies. These are the homogeneous eosinophilic in the epithelium, present in the epithelium. Now in the second one, you can see the lymphocytic infiltrate because the radicular cyst is inflammatory in origin. So FNAC when we see there is the cystic fluid shows a shimmery effect due to the presence of the cholesterol crystals. So another histopathological features, we see the cholesterol cleft crystals. Basically these are pentagonal in shape. These are stained. What is the difference between crystals and clefts? These are seen when before staining. So after staining we see the clear spaces. During the sectioning that are removed, cholesterols are removed, we see the clefts. And Russian bodies are the arc shaped of the curvilinear eosinophilic homogeneous type of the substances present in the epithelium. So what is the pathophysiology of the Russian bodies? We know that inflammation in the radicular cyst, there occurs the diabetes of RBCs. RBC starts to break down. The wall of RBCs, we called it as the Russian bodies, and there may occur the dystrophic calcification in these walls of RBCs. And another one, Russell bodies. These are different from the Russian bodies. These are the immunoglobulins formed by the plasma cells. And plasma cells are also seen in the radicular cyst, having the cartwheel appearance of the nucleus and the eccentric presence of nucleus. Now this was all about the histopathology. Coming to the treatment of the radicular cyst. As we know that there is a non-vital pulp, so we have to go for the RCT, and sometimes we have to go for the extraction of the teeth.